Hello everyone, today we'll be discussing heart failure. This presentation will provide us with an in-depth understanding of heart failure, covering its fundamentals, clinical presentation, diagnosis, management, and multidisciplinary care approaches. Overview: we'll explore the fundamentals of heart failure, including its definition, causes, and pathophysiology. Thereafter, we'll review the clinical presentation and diagnosis methods, then management strategies, including lifestyle, medications, and advanced therapies will be discussed. And we'll conclude with the monitoring progress and the role of a multidisciplinary team in the management of heart failure. Understanding the fundamentals of heart failure. Heart failure is a complex clinical syndrome that is characterized by the heart's inability to pump sufficient blood to meet the body's needs. It affects millions worldwide with increasing prevalence due to aging populations and comorbidities such as diabetes and hypertension. The etiology of heart failure includes ischemic heart disease, hypertension, cardiomyopathies, and valvular disorders. Risk factors such as obesity, smoking, diabetes, and sedentary lifestyle significantly contribute to its development. Pathophysiology and classification. Heart failure pathophysiology involves impaired ventricular function, neurohormonal activation, and remodeling. It is classified based on ejection fraction into heart failure with reduced, preserved, or mid-range ejection fraction, each with distinct clinical implications. Clinical presentation and diagnostic evaluation. Signs, symptoms, and stages of heart failure. Common symptoms include dyspnea, fatigue, and edema. Heart failure is staged into A to D based on the severity and risk, guiding clinical management and prognosis. We are going to discuss the various ways in which we classify heart failure as well as management modalities based on the stages in the coming slides. Physical examination and patient assessment. Assessment involves checking for jugular venous distension, lung crackles, peripheral edema, and measuring vital signs that indicate cardiac function as well as fluid status. Diagnostic evaluation includes natriuretic peptides, echocardiography, chest X-rays, and stress tests to assess cardiac structure, function, and severity of heart failure. So under echocardiography, that uses ultrasound to provide images of the heart structure and function. This aid with diagnosis of heart condition. It will tell us the ejection fraction. It will tell us about the valve, the cardiac muscle. Then chest X-ray. They assess the heart size and lung condition that can support heart failure diagnosis and management. Management strategies for heart failure. Effective management combines lifestyle changes, pharmacological treatments, and when necessary, device-based therapies or surgical interventions tailored to individual patient profiles. Lifestyle modification and patient education, sodium restriction, fluid management, exercise, and smoking cessation are vital. Educating patients improves adherence and outcomes. Pharmacological treatment options. Medications include ACE inhibitors, beta blockers, diuretics, aldosterone antagonists, and we've got newer agents like ARNI, which improve symptoms and reduce mortality. Okay, let's do this. Life-based therapies and surgical interventions. Advanced heart failure may require devices such as ICDs or CIT and surgical options like ventricular assist devices or transplantation in selected cases. Monitoring prognosis and multidisciplinary care. Ongoing monitoring and understanding prognosis are crucial for optimal care. Multidisciplinary teams enhance management by addressing diverse patient needs holistically. Regular monitoring through clinical assessments and biomarkers like BNP help track disease progression and treatment response. Prognostic factors include ejection fraction, comorbidities, and functional status. Advanced heart failure poses significant challenges requiring specialized intervention. Role of a multidisciplinary team in management. A team involving cardiologists, nurses, dietitians, pharmacists, and social workers ensures comprehensive care, improves adherence, and enhances quality of life for heart failure patients. Conclusion: understanding heart failure's complexity enables healthcare professionals to provide effective diagnosis, management, and support. A comprehensive and multidisciplinary approach is essential to improve patient outcomes and quality of life. Heart failure, a brief summary. So when we talk about heart failure categories, they can be categorized according to the stages, according to ejection fraction, according to the NEHAP class, okay? When we talk about the stages, we've got stage A to D. When we talk about stage A, these are patients that are at risk for heart failure. So there are no heart failure signs or symptoms. There is no structural or functional heart disease and no abnormal biomarkers. Then when we go to stage B, that is pre-heart failure. No heart failure signs or symptoms. However, they do have one of the following, which is 1. Either structural heart disease, 2. Increased filling pressures, 3. Risk factors plus increased natriuretic peptides or persistently increased cardiac troponin without competing diagnosis. Then stage C is symptomatic heart failure, structural heart disease, as well as current or previous heart failure symptoms. Then stage D is advanced heart failure, that is heart failure symptoms that are interfering with normal activity and a recurrent heart failure hospitalization. Then categorization according to ejection fractions. So heart failure with reduced ejection fraction, that is whereby there is left ventricular ejection fraction of less than or equal to 40%. Then we've got heart failure with improved ejection fraction, which is left ventricular ejection fraction of above 40%. So what this means is this was somebody that had an ejection fraction of below 40%, and then after therapy and treatment it went to above 40. So in this case, that will be improved ejection fraction, okay? Then heart failure with mildly reduced ejection fraction, that is left ventricular ejection fraction of between 41 to 49%, with evidence of spontaneous or provocable increased left ventricular filling pressures. Then heart failure with preserved ejection fraction, that is whereby there is left ventricular ejection fraction of greater than or equal to 50%, with evidence of spontaneous or provocable increased left ventricular filling pressures. Then we have got the NEHA classification, which is the functional classification. So 1, where there is no symptoms from ordinary daily activities. NEHA class 2, no symptoms at rest. Ordinary daily physical activities cause heart failure symptoms. Stage 3, no symptoms at rest. Activities lighter than ordinary daily physical activities cause heart failure symptoms. Then stage 4 is whereby you have got symptoms at rest. Discomfort worsens with physical activities. So what are the goals of therapy? So for stage A, we need primary prevention of heart failure. Stage 2, prevention of clinical heart failure. Stage 3, reduction of mortality, reduction of heart failure symptoms and hospitalization risk, elimination of potential barriers to self-care. Then stage D, provision of inotropic support until mechanical circulatory support or cardiac transplantation is available, palliative symptom control and functional improvement if not eligible for mechanical circulatory support or cardiac transplantation. Pharmacotherapy recommendation. So for stage A, we need to control blood sugar in patients that have got hypertension. Then SGLT2 inhibitors in patients that have got type 2 diabetes mellitus plus established cardiovascular disease or high cardiovascular risk, as well as managing existing comorbidities. Then step B, ACE inhibitors and evidence-based beta blockers in patients with left ventricular ejection fraction of below 40%, in left ventricular ejection fraction of less than or equal to 40%, and recent MI, use angiotensin receptor blockers if ACE inhibitors are not tolerated. Stage C, heart failure with preserved ejection fraction. So in such cases, we need to use SGLT2 inhibitors in all patients with heart failure with preserved ejection fraction unless it's contraindicated. May consider mineralocorticoid receptor antagonist or angiotensin receptor neprilysin inhibitor if left ventricular ejection fraction is below 55 to 60%. May consider regardless of left ventricular ejection fraction for female patients, and may consider angiotensin receptor blocker if unable to receive ARNI therapy. Then PRN, you can use a loop diuretic if there are congestive symptoms. Stage C, heart failure with mildly reduced ejection fraction, which is 41 to 49%. PRN diuretics, and the diuretics that are preferred are loop diuretics such as furosemide. SGLT2 inhibitors may be beneficial. Then may consider mineralocorticoid receptor antagonist as inhibitor ARBs or ARNI and evidence-based beta blocker, particularly if left ventricular ejection fraction is closer to reduced ejection fraction threshold. Then stage C, that is heart failure with improved ejection fraction. So you continue the medical therapy that was already started earlier. Even if the patient is asymptomatic, you do not hold off the medication. Then we go to stage C, heart failure with reduced ejection fraction. So in all patients, you use ARNI or ACE inhibitor or ARBs. ARNI used in NIHA class 2 to 3, ACE inhibitor or ARBs in NIHA class 2 to 4. And the order of preference is ARNI is better than ACE inhibitor, which is better than angiotensin receptor blocker. Then what we need to know is that you need a 36-hour washout required when switching between ACE inhibitor and ARNI and vice versa. Then beta blocker evidence-based, bisoprolol, carvedilol, metoprolol. We can use any of these. Then MRA example are eplerenone or spironolactone used in NIHA class 2 to 4. Estimated GFR of greater than 30 mL per minute or with a serum potassium of below 5. SGLT2 inhibitors need to be used with or without type 2 diabetes mellitus, and diuretics, it's as needed, okay? And the preferred diuretics are loop diuretics. Then specific patients, hydralazine plus isosorbide dinitrate used in African American patients on optimal therapy, NIHA class 3 to 4, ivabradine, NIHA class 2 to 3, and left ventricular ejection fraction of less than or equal to 35%. On JDMT, including maximum tolerated beta blocker, NSR with resting heart rate of greater than or equal to 70 beats per minute. Then vericiguat in NIHA class 2 to 4 and left ventricular ejection fraction of below 45%. Recent heart failure worsening or increased BNP or NT-proBNP. Then digoxin if symptomatic despite JDMT or unable to tolerate JDMT. Potassium binders such as patiromer, sodium zirconium, cyclosilicate, patients with hyperkalemia whereby the potassium is above 5.5 milliequivalents per liter. Then omega-3 PUFA may be considered as an adjunct in NIHA class 2 to 4. And there are a few medications that may cause or exacerbate heart failure that include COX inhibitors, thiazolidine diones, saxagliptin, alogliptin, flecainide disopyramide, sotalol, dronedarone, doxazosin, diltiazem, verapamil, as well as nifedipine. That's all about heart failure. If you like the video, please like, subscribe, and comment. Thank you.